Welcome to the Congenital Talk for TRP 2021. Hopefully by now, you've all either taken your congenital rotation or in the process of completing it. You realize that the topics in congenital are very different from what we do in the adult world. However, as with studying for your adult topics, the key to covering congenital topics is organization. I have some basic objectives for this lecture in the short amount of time that we have. I want to briefly discuss the classification of congenital heart disease. I know for a fact that the ability to organize information will help you understand and recall necessary details when required. We'll run through a mock case and some of the relevant details you should ask for when taking a history on your oral exam. We'll then walk through the mechanics of the actual repair. Finally, we'll review some of the imaging that you should find useful in your exam as well. I found that some of the most challenging parts of studying was the basic skill sets that are not explicitly taught while you're in residency, this being interpretation of CT, echocardiography, and other imaging. Although we pick up these basic skills during our residency, when you're in your exam, you need to be able to interpret these images rather quickly so you can move forward with the case. In terms of the topic list, this represents most of the pathologies you're responsible for managing. A key principle in covering these topics is understanding the underlying anatomy behind each process. Once you have an understanding of the anatomy, the physiology becomes predictable and the actual surgical approach becomes very logical. The operations for each are designed to be as simple as possible while attempting to recreate normal anatomy and physiology. This means securing stable pulmonary and systemic blood flow while relieving any level of obstruction. Going through this list, some topics will be higher yield than others, and it's wise to focus your attention on higher yield items. Now, this is going to be different for people who are writing their exam in the next few months, as opposed to people who are writing a few years from now. If you're writing the next few months, it would be wiser to have an in-depth understanding of the various types of VSDs and tetralogy and their detailed management, as opposed to focusing on a more complex, controversial topic such as complex heterotaxy AV canal disease. Regardless of where you are, you should have a reasonable grasp on most of the items in this list and be able to walk through a case. You should be able to take an appropriate history, understand the pertinent findings, go through the radiographic workup, and plan an operation and execute that operation. There are a few topics that deserve special attention in congenital heart disease. One of these topics is the SingleValve Pathway. You've probably had the opportunity to see a few Norwood operations, bidirectional Glens, or Fontans on your congenital rotation. If you haven't seen them, you can find them on MMCTS or on YouTube, and you should review some of these videos. You should be able to describe the operative steps for each of these operations. Typically, most centers use the same technique for a Norwood operation with a few modifications that are center specific. Details that vary would be whether they use a BT shunt or a Sano shunt and the order in which they conduct the operation. The bidirectional Glen is pretty straightforward and usually done either on pump or off pump at most institutions. In terms of the Fontan, most centers are using the extracardiac Fontan. If you haven't seen or scrubbed on this operation, that's the operation you should probably describe. If your center uses a lateral tunnel or atrial pulmonary connection, then it's fine to use that technique as well. Now, we use this pathway to treat three broad categories of congenital disease. The first category is atrioventricular valve atresia. Now, tricuspid atresia and mitral valve atresia fall into this category. As you know, ventricles require flow to grow. When you have an atretic tricuspid valve or mitral valve, it usually manifests as ventricular hypoplasia. Now, this takes me to the second category of congenital disease that we use a single ventricle pathway for. That's ventricular hypoplasia. Syndromes that fall into this category are hyperplastic left heart syndrome, double inlet left ventricle, double inlet right ventricle, and unbalanced AV canal disease. The third category would be outflow tract obstruction. Now, this includes Schoen complex and pulmonary atresia with a small or hypoplastic right ventricle. Another important pathway to understand is device therapy and transplantation. Fortunately, depending on the size of the patients, we can rely on the same systems used in adults to treat children. As we move towards the smaller children, we tend to shift away from CentroMegs and use PDMegs. A key point to remember is that we cannot use device therapy as destination therapy in children. They're always used as bridge to recovery, or bridge to transplant, or in some cases, bridge to decision. The techniques of transplantation are again very similar to that of adults, with the exception that we still rely on both biatrial and bicable techniques. Either is acceptable, and you should rely on whichever method you've observed in the OR. You've probably already reviewed the transplant listing criteria used in Canada. Remember that although the categories are the same, there are important differences within each category when describing the listing for children. It's worth reviewing. The single most important classification system you need to remember is the difference between cyanotic and non-cyanotic heart disease. You should be able to recite from memory items from each of these lists and how their management pathways differ from each other. Remember, to a cardiac surgeon, cyanosis is the manifestation of decreased pulmonary blood flow. The treatment is to correct the underlying anatomical problem. If that's not possible, then we'll use a palliative shunt in order to increase pulmonary blood flow. Any anomaly that results in anatomy with decreased pulmonary blood flow will result in cyanosis. The one exception to this rule is patients that have developed MAPCAs, basically major aortopulmonary collaterals, and this occurs at birth. Or in the case of single ventricles, over time they can develop large AP collaterals from long-standing hypoxia. Whenever you're asked to recall cyanotic lesions, the first thing to recall are the 5 T's. Tetralogy at Fallot, along with its 4 variants, that's tetralogy with pulmonary stenosis, with pulmonary atresia, with MAPCAs, which are major aortopulmonary collaterals, and TED-absent pulmonary valve. You should know how to manage all the variants. For DTGA, whether they're cyanotic is going to be dependent on how much mixing is happening, and that's whether they have a restrictive atrial septum or a large ASD, or DTGA with a ventricular septal defect. For tricuspid atresia, you need to know the types, type 1 or type 2, and the subsets A, B, and C. Type 1 being normally related great vessels, and type 2 being DTGA. The subsets A, B, and C refer to the morphology of the pulmonary valve, type A being those with a pulmonary valve atresia, subset B being those with a stenotic pulmonary valve, and subset C being those with a normal pulmonary valve. For TAPVR, you should know the difference between the supracardiac, cardiac, and infracardiac variants, and which is more likely to present with obstruction and how to manage that. For truncus arteriosus, you should be familiar with both the Clapp-Edwards and Van Praag systems. You should also be able to draw all those variants. As with cyanotic heart disease, you should have a system for remembering the non-cyanotic heart disease variants. It's wise to remember that ASDs, VSDs, and balanced AV canals never present with cyanosis, as they usually result in increased pulmonary blood flow. The only time these disorders present as cyanotic heart disease is when patients develop pulmonary hypertension, as in the setting of Eisenmenger syndrome. Now, these patients' clinical picture changes as babies age, as PVR changes relative to SVR. When you're determining ASD flow, it's determined based on ventricular compliance, and this changes with time as well. Now, obstructive lesions are non-cyanotic, and they should be grouped together. There are various levels of obstruction, and if you think of them anatomically, it's easy to remember them. You can start proximally inside the alveoli, looking at subaortic membranes. There's aortic valvular obstruction. There's supravalvular obstruction, as within Williams syndrome. There's arch hypoplasia, and there's aortic coarctations. This is the case presentation. We'll walk through the case together. So baby Kelly is a 12-month-old who's been referred to you for heart murmur on exam in their pediatrician's office. How would you like to manage this patient? The first thing you do is ask for complete history and conduct a physical exam. Ask for a full set of vitals and make sure there's no concerning elements early on in the case. The examiner will give you pertinent findings or simply move you along in the interest of time. So on history, aside from being born at 6 pounds, there's nothing really relevant. There are no pertinent findings on past medical history, surgical history, no medications, and no relevant social history. So on physical exam, we are also given the vitals. The vitals seem normal. The weight is 7.4 kilograms and the saturation is 100%. There's no pertinent findings on general, aside from being acyanotic. Head neck exam, unremarkable. On chest, we see that the S1 is normal and S2 is physiologically split. There's a grade 3 out of 6 systolic murmur. Aside from that, no other findings. So what investigations would you like? At this point in time, I'd start with an ECG, order a plain film chest x-ray, and get a transthoracic echocardiogram. Now, according to the case, the ECG was unremarkable, the chest x-ray was unremarkable, and I'm being asked to interpret an echocardiogram. So I see the transthoracic echo. It's a peristernal long axis left ventricular outflow tract view. I see normal left ventricular function, normal mitral valve motion, normal aorta, and somewhat enlarged right ventricle. There's no evidence of VSD in this view. This is a transthoracic peristernal long axis RVOT view. I see the right ventricular outflow tract proximally is shown at the top of the screen with a normal pulmonary valve. Mid-screen, the function looks good. The MPA is visible distally at the bottom of the screen. The MPA seems somewhat dilated. This view is the peristernal short axis atrial septum view. I see the aortic valve centrally. To the left, I see a tricuspid valve which is functioning normally, but it seems somewhat large. The atrial septum appears to be missing, and there's a small posterior rim visible in that region. I would diagnose an atrial septal defect, but I need more images to confirm my diagnosis, and I would review these images with an echocardiographer. This is the peristernal short axis PA view. I see the branched pulmonary arteries. I see the right ventricular outflow tract at the top of the screen. The pulmonary valve comes into view with each beat. It appears to be functioning normally. The MPA does seem somewhat large, and the branched PA seems somewhat large as well. Aside from that, I see no other findings. This is the peristernal short axis view, cutting the ventricles. LV function looks normal, and the right ventricle appears dilated. This is an apical four-chamber view. I see deficiency in the mid portion of the atrial septum suggestive of an ASD. The tricuspid valve looks normal. The RV appears dilated. LV functional and mitral valve look normal. I need color to determine if there's flow across the ASD. This is the same four-chamber view demonstrating the atrial septal defect with color. There's a clear left to right shunt across this ASD. This is a transthoracic subcostal view of the intraatrial septum. I see the left atrium as the top chamber and the right atrium directly underneath. I see a superior and inferior rim of the ASD. There is some right atrial dilation. Aside from that, the right ventricle, left ventricle, mitral valve, and tricuspid valve appear as previously described. This is the same view with color demonstrating flow towards the echo probe, highlighting a left to right atrial shunt. So I'm being asked a series of questions now. First question was my diagnosis. My diagnosis is secundum atrial septal defect. I would manage this patient by 1, getting an MRI to quantify a QP-QS ratio, as well as refer to a pediatric cardiologist. As far as the need to operate, there's no need to operate at this point in time. We can continue our workup. There's no evidence of heart failure or failure to thrive. So at this point in time, the baby's care is advanced. She's seen by cardiology, and MRI demonstrated a QP-QS ratio of 1.7 to 1. The patient was discussed in a multidisciplinary conference and referred for a cardiac cath. The QP-QS ratio was confirmed in cardiac cath. There's no evidence of pulmonary hypertension. The cardiologist determined on cath that there's inadequate rooms for device closure, and they're recommending surgical closure. So we're being asked a series of questions now by the examiner. The first question is, what are the indications to operate in this patient? Since they're not experiencing any symptoms of congestive heart failure and no failure to thrive, and that the fact that they've been growing, they have no immediate indication for an operation. Their QPQS ratio is elevated, and their echo did demonstrate right ventricular overload, so they will need an operation at some point, just not in the immediate future. The second question is, what's the risk of this patient's life in the short and intermediate term? The risk to this patient's life is very low, short and intermediate term. ASDs are very well tolerated for several years. The third question is, when would you operate and why? I would plan for an elective operation around 2 years of age. The benefit of waiting is that we can plan for a bloodless operation. That is, we don't need to transfuse them given their expected growth by 2 years of age. At that point in time, they'll be young enough that they won't remember the operation, so there will be less psychological trauma, and there's plenty of time to plan for an elective operation. The final question is, what are the 5 types of atrial septal defect? The 5 types would be a PFO, a secundum ASD, a primum ASD, a sinus venosus defect, and an unroofed coronary sinus. So in this slide, we're being asked to describe the operation. When you're asked to do this, start out by describing the operation in as much detail as possible. If you're providing too many details, the examiner will give you a cue to speed up. In terms of my approach, I'd approach through sternotomy. I'd take out the thymus, so I have additional room to work. I'd harvest autologous pericardium. I treat in glutaraldehyde. I place suspension sutures in the pericardium to bring the heart up. I'd heparinize to an ACT greater than 550. I'd cannulate the ascending aorta, bicavally cannulate the venous system, put on cable tapes. My planned flow rate would be an index of 1.8 to 2 liters per minute per meter square. I'd passively drift in terms of temperature to 34 degrees Celsius. My cardioprotection strategy would be to utilize Delnito cardioplegia to deliver 30 cc's per kilogram in an antegrade fashion into the aortic root. After applying my crossel lamp and arresting the heart, I'd open the right atrium using a standard oblique incision. The first thing I do after I've opened the right atrium is identify all relevant landmarks in the atria. That means the IVC, the SVC, coronary sinus, eustachian, the Besson valves, tricuspid valve. If the ASD is very large, I'd look over to the left side and identify the locations of the pulmonary veins. The reason why I do this is to make sure that when I'm sewing my patch in, I leave the pulmonary veins on the left side of the heart. I did mention before that I would actually use CO2 in the well, which is going to help me de-air later on. I'd close the ASD by suturing in my autologous pericardium, which has been treated with glutaraldehyde. The rough side would be on the right atrial side, and the smooth surface would be on the left atrial side. I do this with a Prolene suture. After completing the suture line, I'd confirm my SVC and the IVC are still on the right side of the heart to make sure I didn't accidentally take it over the left side. Prior to tying in my patch, I'd give a puff on the lungs to de-air the left atrium. I would then start closing my right atriotomy with a Prolene suture. I put the head down, release my cross clamp, and turn my cardioplegia site into a root vent. As the heart reperfuses and returns to normal function, I place atrial ventricular pacing wires. Typically, we use modified ultrafiltration at our center, so once the heart's reperfusing, I wean out bypass and muff for 10 minutes. I then confirm my repair and interrogate overall function using intraoperative transesophageal echocardiography. So that represents the bulk of what a simple congenital case is. It asks you to take a history, work through some imaging, make a diagnosis, demonstrate proficiency in the OR. Now, an examiner can ask you to dive into more details at any point in time, or they can give you a complication to work through. An important point to remember is that the general conduct of the bypass case is very similar to that of the adult world. The principles of bypass and neuroprotection and cardioprotection are all very similar. One thing to remember is that you should only use techniques that you've seen before and are comfortable using. Don't make up operations. When in doubt, use exactly what's being done at your center. Now, I mentioned early in the objectives I wanted to cover this topic at the correct level of depth of the exam. So we're going to talk a bit more about right atrial anatomy as it pertains to the case we discussed. Now, you should be very familiar with this diagram. On the right, you should be able to draw all the structures inside the right atrium and demonstrate their correct anatomical relationships. The reason why this is so important is it's the key to doing the actual repair. Every time we open up a right atrium, we identify our landmarks. We need to know where the IVC and the SVC are, where the coronary sinus is, where the trapezoid valve septal leaflet is, and then finally we identify the actual defect that we're there to repair. If you don't do this, it's easy to sew a patch into the wrong plane and create a right to left shunt, or even leave structures that belong on the left side of the heart over on the right side. Remember that secundum ASDs are always located in the fossa ovalis. They can be a small perforation of the septum primum, or they can be complete absence of the septum primum. It's an assessment you'll have to do visually once you've opened up the right atrium. Now, if you look to the diagram on the left, you should be able to point out the coronary sinus, tricuspid valve, septal leaflet, and where you'd sew your patch. I mentioned that there's 5 types of ASDs earlier on during the case discussion. It's important that you recognize the location of each type and understand the relationship to each other and the other important structures in the right atrium. You could be asked to draw these relationships on your written exam or on your oral exam. Now, the most common type of ASD is going to be your secundum ASD, with primum defects representing about 20% and sinus venosus defects being about 5 to 10%. The remaining are coronary sinus defects, and that's about 1%, they're relatively rare. The physiologic issue for all these ASDs is the same. You volume load the right heart, leading to dilation of structures, arrhythmias, and eventual Eisenmengers. Now, for patients who are asymptomatic as babies, as they grow into adulthood, they will experience exercise intolerance and eventual atrial arrhythmias and possibly paradoxical emboli. Now, we've been taught that small ASDs in childhood that are less than 5 millimeters may close on their own. Typically, the other types of ASDs will not close on their own and they require management. This figure simply depicts a few different ways to close simple ASDs. If they're small or PFOs, they can be suture closed with simple 5-4-6-0 Prolene. As they get larger, trying to primarily close an ASD can result in a change in the geometry of the atria, so it's wiser to use some form of patch material. To be honest, it doesn't matter what you use. You can use 0.6 millimeter Gore-Tex, you can use homograft, you can use Talus pericardium, you can use bovine pericardium. As long as it's sutured in a secure fashion, then it'll work just fine. It's important to remember that if you do use autologous pericardium, bovine pericardium, those materials are sided, meaning that you have to put the rough side on the right atrial side and the smooth side on the left atrial side. There have been documented cases of stroke when this is accidentally reversed. Usually post-operatively, these patients are put on aspirin, again, to further reduce the risk of thrombus along that patch material. Sinus venosus defects are typically associated with anomalous pulmonary veins to the SVC or IVC. It's rare that you won't find anomalous veins, and if you're in a situation where there are no veins, you can just do a direct ASD closure. For the majority of the time where you do have these anomalous veins, you have to have a strategy for dealing with them. Typically, if they're located closer than 1.5 centimeters from the cavoatrial junction, you can try direct baffle. If the distance is greater than that, often the baffle pressure will push up into the SVC or IVC and obstruct those vessels. For that reason, we use an alternative approach. One of those alternative approaches is a 2-patch repair. It's kind of an old school technique which has fallen out of favor at some institutions, but it's worthwhile looking up as you might need to describe it. Now, the third option you've probably heard of, it's a Warden procedure. It's commonly used, and it tends to be a higher yield procedure to use on a oral exam or written exam. So for that reason, we'll go into a little bit more detail surrounding Warden. Essentially, what you do is you bicavally cannulate high on the SVC or low on the IVC. You ligate the ascus vein, divide the SVC, and oversew it. The stump should be safely away from the SA node. You place a right atrial patch baffling the pulmonary vein into the left atrium. You then anastomose the SVC to the right atrial appendage, completing the Warden. Now, we previously talked about the indications to operate on ASDs. We talked about congestive heart failure, failure to thrive. We talked about a significant shunt being greater than 1.5 to 1. Now, it's important to remember that QPQS slowly increases with time as LV compliance decreases. Only a small percentage of patients, about 5 to 10%, progress to pulmonary vascular disease by the end of their second decade of life. The progression of this pulmonary vascular disease is far more pronounced with VSDs, which is why we operate on them much sooner in life. If you don't repair these atrial defects, what happens is as they approach their fourth and fifth decade of life, they tend to develop exertional symptoms. This is most likely from decreased LV compliance, resulting in increased shunting. So with that in mind, we do try to repair these ASDs earlier on in life. Now, a good rule of thumb is that when an infant presents with CHF or failure to thrive, you should plan to close that ASD in infancy or as a toddler. Now, when you have a small ASD less than 5 millimeters, you can wait to see if it closes on its own. If it doesn't close after 12 months and you have evidence of right ventricular volume overload, you can plan for closure over the next year or two. We know that closing ASDs accelerates growth recovery on the growth curve. Remember, cyanosis is not a feature of this disorder unless Eisenmenger's syndrome is present. And if you do have Eisenmenger's, you definitely should not close that atrial septal defect. Just a quick comment on the timing of our operations. Traditionally, we used to close these around 4 to 5 years of age. Nowadays, it's done closer to 2 years of age. The main reason for this is that if you wait to 2 years, you don't have to transfuse them. They're large enough that you can perform a bloodless operation. Now, with that said, there's other benefits in terms of psychological effects of surgery. These children tend not to remember the operation at that age. Plus, it's easier for families to plan around when to get this repaired, seeing as these children aren't in school yet. Now, if a patient does have some mild symptoms of heart failure, you can treat them medically, and typically our cardiologists do that for us, but digoxin and diuretics tend to be the most common cocktail used. Echo is a very high yield review topic in congenital cardiac surgery. We spend a lot of time managing patients, but we rarely make the diagnosis ourselves. We expect other physicians to do that for us. The exam setting is a little bit strange in that you're going to be expected to make this diagnosis on your own and then base your management on your diagnosis. For that reason, there's a lot of value in reviewing what normal echoes look like, as well as what the individual pathologies you're expected to recognize look like. This is the parasternal long axis left ventricular outflow tract view. This is a good view to profile the mitral valve, left ventricle, and left ventricular outflow tract, as well as flow across the mitral and aortic valves. When looking at this view, be sure to comment on leaflet mobility and excursion of the mitral and aortic valves, thickness of the ventricular septum, as well as ventricular function and chamber size. A number of pathologies can be found on this view with interrogation. A few pathologies you should look for are subaortic membranes, mitral valve dysfunction, ventricular septal defects, aortic valve disease including root dilation. You can see pericardial effusions. You can also see corner truncal abnormalities such as truncus arteriosus and detransposition of the great arteries. In this example, we demonstrate the value of the parasternal long axis LVOT view. When you're reading these echoes in an exam setting, always start reading the echoes the same way. Name the view. If you can't name the exact view, then list the type of study, a transthoracic or a transesophageal echo. Then state whether it's a short axis or a long axis view. Finally, point out the individual chambers as you read it. This will help you organize your thoughts, and then list the apparent pathology. When you look at the loop above, what comes to mind? It doesn't look quite right. First, start out by identifying the chambers. Given the fact that we're looking at a parasternal long axis view, we know where the right ventricle and left ventricle apices are. If we follow the left ventricle out towards the outflow tract, we start to see the abnormality right around the valvular structure. That doesn't look like aortic valve. It looks more like a pulmonary valve, and we can confirm our diagnosis by looking even more distal where it branches into pulmonary arteries. So this clearly is detransposition. This is the parasternal long axis view tilted anteriorly. It's a good way to profile the distal right ventricular outflow tract and assess the pulmonary valve morphology and main pulmonary artery. In this particular view, you should comment on the distal right ventricular outflow tract, that it appears of appropriate caliber, that the pulmonary valve leaflets appear thin and mobile with good excursion, and the main pulmonary artery appears to be of normal size. When you're looking at this view, you should be able to identify a patent ductal arteriosus that is on an abnormal exam, any kind of pulmonary valve abnormalities, whether it's stenosis, supravalvular stenosis, or pulmonary regurgitation, as well as levels of right ventricular outflow tract obstruction. That's namely tetralogy, double-chambered right ventricles, and any right ventricular outflow tract aneurysm. This is an example of the peristernal long axis pulmonary valve view. Quickly review this echo and comment on your findings. In 5 seconds, I'll move forward. So now that you've had a chance to review this echo, you should be able to comment on the fact that there's a small pulmonary valve, which is borderline hypoplastic. You should be able to comment on the turbulent flow across the pulmonary valve consistent with stenosis. If you follow the flow distally to the main pulmonary artery, you can see a PDA demonstrating left-to-right shunting. Your differential while looking at this view should include all pathologies with right ventricular outflow tract obstruction. This patient in particular is a TOF patient. Another view confirming a VSD would be enough to make a diagnosis. This is the peristernal short axis branch PA view. It's also known as the PANTS view. It's obtained from the high peristernal short axis position, and it's used to profile the distal main pulmonary artery and branch pulmonary arteries. Now, this is a normal study, and you should be able to comment on the fact that the outflow tract appears normal, that the pulmonary valve leaflets are normal with good excursion. There's no evidence of stenosis or dilation. If this were an abnormal study, you should be able to pick up pathologies such as branch PA, dilation, hypoplasia, or stenosis. You should be able to comment on main pulmonary artery pathology. You would be able to see aortopulmonary windows as well as a PDA. This is an example of the peristernal short axis branch PA view. Spend 10 seconds to try to identify the pathology. We'll start by identifying the chambers, and then we'll work out what's happening in this view. So we'll start off by identifying the individual chambers. We can identify the main pulmonary artery based on the fact that we can follow it to the RPA and the LPA. We've identified the aorta, and now there's a connection between the aorta and the MPA. This was in fact an AP window. Of course, with any pathology, we look at it with multiple views and other modalities to confirm our diagnosis. This is the peristernal short axis RVOT view. This short axis view is good for assessing the aortic valve, the tricuspid valve, the RVOT, and the atrial septum. Now, when you're looking at this echo, you should be able to comment on the fact that the aortic valve leaflets appear thin with normal excursion, the fact that the aortic valve is trichomonosural, the tricuspid valve leaflets appear normal as well, the pulmonary valve leaflets move nicely and appear normal, the atrial septum in this view is intact, and the outflow tract appears of normal caliber. The different kinds of pathologies you can identify with this view range from bicuspid valves to secundum ASDs, which would show up as a deficiency in the atrial septum, tricuspid valve abnormalities such as Ebstein's. You can see right ventricular outflow tract obstruction, and you should be able to see varying levels of pulmonary stenosis. This is an example of the peristernal short axis RVOT aortic valve view. Spend a few seconds and review the findings, point out any abnormalities. You can start by identifying the chambers which were labeled previously. In 5 seconds, I'll advance the slide. After identifying the chambers, we can start to make sense of the picture. We can see the right atrium, and then we can see the displacement of the tricuspid valve leaflets into the right ventricular outflow tract. This echo is taken from a patient with abstains. Obviously, we do more views to confirm our diagnosis. This is the parasternal short axis mitral valve view. It's obtained from the parasternal short axis, and it's a good way to profile the anterior and posterior leaflets of the mitral valve. If you review this individual echo, you could comment on the fact that the mitral valve leaflets appear to function normally and demonstrate good excursion. Now, pathologies we identify when we're looking at this particular view would be anything related to the mitral valve, specifically prolapse, regurgitation. It's particularly good at identifying mitral clefts that we find with AV canal defects. This is the same view, the parasternal short axis mitral valve view. Review this image and identify the pathology. The slide will advance in 5 seconds. So first off, we identify the relevant anatomy. We identify the anterior leaflet and posterior leaflets of the mitral valve. Clearly there's a defect in the anterior leaflet. This patient has a primum AV canal defect, and this view demonstrates the associated mitral cleft. Other views would confirm the presence of the ASD. This view is the suprasternal notch arch view. Based on this image, you can identify a normal aortic root, a normal arch with expected branching pattern, and no visible evidence of a coarctation. This view is very useful when you're looking for an aortic coarct, as well as any associated arch hypoplasia. It's also used to identify and quantify aortic stenosis. You can pick up any abnormalities of the branching with this view. This is an example of the suprasternal notch arch view. Spend a few seconds trying to identify the abnormality. In 5 seconds, the slide will advance. So after we spend a few seconds and identify the relevant anatomy in our minds, we can follow the ascending arch, which is normal in caliber, to the head vessels. They demonstrate normal branching patterns. Just distal to the left subclavian is the isthmus. There is a posterior shelf in this region with a severe narrowing. This patient has an aortic coarctation. This view is the subcostal long axis LVOT view. This view is excellent at profiling the left ventricle. You can assess caliber and flow across the left ventricular outflow tract and the aortic valve. When looking at this specific echo, you can see that the LVOT is normal, as well as the aortic valve and ascending aorta. The leaflets are thin with good excursion. You see normal systolic function, and you see the connection of the SVC to the right atrium. When looking at this view, you can specifically pick out ventricular septal defects, dysfunction of the left ventricle, and subaortic membranes. This is again the same view, the subcostal long axis LVOT view. Review the series of images and try to pick out the abnormality. In 5 seconds, the slide will advance. We can start by identifying the right ventricle and the left ventricle. Then we move out distally onto the left ventricular outflow tract. It's clear that there's a defect in the septum that's visible just below the aortic valve. When we put a little color on this, we can confirm there's a ventricular level shunt. The remainder of the outflow tract looks pretty normal. This is in fact a perimembranous VSD. Of course, to be certain of your diagnosis, you'd look at other views. So this view should be familiar to you by now. It's the apical 4-chamber view. It's a good view to assess atrial and ventricular size and function. You can also assess the tricuspid valve and mitral valve morphology for evidence of stenosis and regurgitation. If you were to interrogate this view that you see, the mitral and tricuspid valve leaflets appear normal with good excursion. the chamber sizes are normal, and the ventricular function is good. This is another apical 4-chamber view. Take a few seconds to read this echo. The slide will advance in 5 seconds. We start interpreting this echo by identifying the relevant chambers. We identified the RV, the LV, RA, and the LA. It's clear that there's defects in the atrial septum and the ventricular septum. We can see an ASD and a VSD, so this person has a complete AV canal defect. We need further imaging to visualize the mitral cleft. We also need further imaging to determine what Rastelli classification this patient has or falls under. Thanks for taking the time to review this lecture. I know your time is extremely valuable, especially with the exam creeping up in the next few months. Hopefully this lecture provided some sense of structure to your congenital efforts. For me, when I was studying, I found there was never a shortage of information to read. It was always about knowing where to focus my attention. Hopefully this has helped focus some of your attention. If you're writing your exam this year, good luck.